Local anesthesia, basic injection technique. Successful delivery of local anesthetic requires careful consideration of many factors, including the type of injection, safe administration, and effective patient management. Many of the steps necessary to a successful injection are the same regardless of the administration technique, and the basic technique helps ensure appropriate pain control during and after treatment in a safe, effective, and comfortable manner for the patient. The equipment necessary for this procedure is as follows: personal protective equipment, syringe, needle, gauze, anesthetic cartridge, topical antiseptic, optional, topical anesthetic, cotton tip applicator, hemostat or cotton pliers, and blood pressure cuff. Before administering a local anesthetic, assess the patient's health history to determine that he is physiologically and psychologically able to tolerate the proposed treatment and local anesthetic administration, and if necessary, modifying the approach to care. Take the patient's vital signs to determine baseline measurements, include blood pressure, pulse, and respiratory rate. Confirm the care plan with the patient and determine the injections to be administered, along with the sensations that he will experience. Obtain informed consent for the treatment, which is necessary prior to administering any local anesthetic injection. Once the selected local anesthetic is loaded into the syringe, check the armamentarium. First, check that the harpoon is fully engaged into the rubber stopper and that the large window of the syringe is facing up, providing full visualization of the cartridge. The large window of the syringe should face you during the injection so that you can see the amount of anesthetic being administered and to detect a positive aspiration. Next, check the needle bevel orientation. Several manufacturers are now placing indicators of the bevel location on the hub of the needle. The bevel of the needle should face the bone, so that if the needle contacts bone, the bevel deflects over the periosteum, minimizing discomfort and trauma. If the bevel faces away from the bone, the point of the needle may tear the sensitive tissues, causing discomfort both during and after the injection. Position the patient in a supine position with the feet elevated slightly to help prevent syncope. Visualize and palpate to locate the penetration site before inserting the needle. Because of individual variations in anatomical landmarks, adjustments in technique may be indicated based upon the size of the individual skull, location of foramen, and exostosis. For maxillary facial injections, the solution is placed in the vestibule at the height of the mucobuccal fold of the soft tissue of the redder superior alveolar mucosa. The firmer and pinker inferior attached gingiva should be avoided. To locate this general target area, use the cotton tip applicator to gently palpate the injection site to ensure soft tissue entry before inserting the needle. Note the frenum locations and avoid going through any large frena during injections. It can help to pull the upper lip more anteriorly. If you are unable to avoid the large frena, administer the injection slightly posterior to the recommended penetration site. Dry the needle penetration site with a sterile piece of gauze to remove saliva and debris and reduce the risk of infection. Optionally, you may choose to apply a topical antiseptic such as betadine or chlorhexidine to the tissue to reduce the possibility of septic material entering the soft tissues. If betadine is used, the patient must be screened for a possible allergy to iodine. Dry the tissue again and apply topical anesthetic to the needle penetration site for 1 to 2 minutes using a cotton tip applicator. While applying the topical anesthetic, you may choose to use the cotton tip applicator to visualize and practice the angulations necessary for the injection. Remove the topical anesthetic swab from the tissue and dry the penetration site. Make the tissue at the penetration site taut by retracting it, except if you are penetrating the palate. You may use a sterile piece of gauze to help you retract and stabilize the tissue. Avoid jiggling the soft tissues or pulling the lip over the needle tip, which may impair visibility of the penetration site. Pick up the prepared local anesthetic syringe and check the bevel orientation to ensure that the bevel will be oriented toward the bone. Hold the syringe with the palm up and the large window up to allow adequate visibility to observe the speed of injection and positive or negative aspirations. Try to keep the syringe and needle out of the patient's line of vision to minimize anxiety. Never bring the syringe across the patient's eyes, but instead place the syringe behind the patient's head and, using the non-dominant hand, cover the patient's line of sight. Establish a firm hand rest to provide stability and control during the injection. Use the fingers from the non-dominant retraction hand to stabilize the syringe. Place the pinky finger of the dominant hand on the patient's chin for further stability. The palm should be up, and the thumb in the thumb ring should be above the knuckle. Take care not to allow the thumb ring to slip down to the bottom of the thumb, which will make it difficult to achieve the full range of backward motion needed for a successful aspiration. Slowly move toward the target. A few drops of anesthetic will inadvertently release a head of the needle from the gentle contact of your thumb on the inner surface of the thumb ring. This action will provide additional patient comfort. Proceed slowly, using appropriate angulations to the depth of needle penetration, which is the target location or deposit location of the anesthetic. Gently insert the needle into the mucosa, keeping the tissue taut until the bevel is completely under the tissue. Observe and communicate with the patient, and watch for any signs of discomfort or distress. Aspirate on arrival at the deposition site to prevent the possibility of an anesthetic solution being injected directly into a blood vessel. Aspiration of blood into the cartridge indicates intravenous placement of the needle. Ascertain whether the needle tip is located within a blood vessel by pulling the thumb ring back gently, only 1 to 2 millimeters. The tip of the needle must remain unmoved in the tissue. If it moves, another aspiration is required. Rotate the barrel of the syringe approximately 45 degrees and aspirate a second time, known as aspirating on 2 planes, to guard against a false negative aspiration. False negative aspiration may occur if the needle bevel is occluded by the inner wall of the blood vessel. Multiple aspirations with the needle bevel in different planes prevent this potential problem. If no blood appears, a negative aspiration, slowly deposit the local anesthetic solution at a rate of 1 milliliter per minute for approximately 2 minutes for a full cartridge. In highly vascular areas, such as with the posterior superior alveolar and inferior alveolar block, aspirate more than once during the injection. Observe and communicate with the patient and watch for any signs of discomfort or distress, reassuring him with statements such as, "I am depositing the solution slowly, so this procedure will be comfortable for you." Slow deposition is critical to prevent an adverse drug reaction. It reduces the risk of inadvertent intravascular injection and the severity of an overdose reaction in case inadvertent intravascular injection occurs. It also prevents tearing and necrosis of the tissue and subsequent discomfort. Any blood entering the cartridge is considered a positive aspiration. If only a small amount of blood has entered the cartridge and does not obstruct the view of successive aspirations, slightly reposition the needle a few millimeters and reattempt the aspiration. If the second aspiration is negative, deliver the anesthetic. If, however, blood fills and clouds the cartridge, or a second aspiration cannot be clearly seen after redirection, remove the syringe from the tissue, change the cartridge and needle, and reattempt the procedure. When the indicated amount of anesthetic has been deposited, slowly withdraw the needle. Replace the needle sheath with the one-handed scoop technique using a recapping device. Rinse the patient's mouth to wash out any anesthetic solution that may have dripped into the mouth. Anesthetic solution has a bitter taste. Observe the patient after the injection. Most adverse reactions, such as syncope, occur either during the injection or within 5 to 10 minutes after you have completed administration. Record the injection or injections in the patient's chart, including the area anesthetized and specific injection or injections given, the type of anesthetic used, and type of vasoconstrictor and its concentration, ratio, the total amount of solution administered in milligrams, and any patient reaction.